Hello, everybody. Welcome to today's Complex Pediatrics Echo Clinic. So glad you could join us. We'll start off with introductions. So I'm Troy Jorgensen. I'm the program manager here for Project Echo Nevada.
I'm Amy Lansing. I'm a pediatric psychologist and professor up at the university and collaborate with all the Peds Endo folks on psychosocial health.
I'm Lori Nielsen. I'm the pediatric nurse practitioner over in the renowned Pediatric Endocrine Clinic.
My name is Stephen Compston. I'm a registered dietitian and certified diabetes care and education specialist at renowned Pediatric Endocrinology.
Okay, I don't have quite that mouthful, but I am a pediatric endocrinologist and director of the Complex Pediatric Project Echo.
All right. So we'll go out to all of you joining us today. So we'll start off with Caroline. Oh, just a second there. Go ahead.
Hi, I'm a graduate student at UNR in the clinical psychology program, and Amy is my faculty advisor.
I'm Tori. I'm also in the clinical program with Amy as my advisor as well.
Wonderful. Glad to have you both with us today. Next, we'll go to, I think it's Donna Crowley. Is that right? Donna, are you there? Could you introduce yourself first, please? Okay, maybe we don't have a microphone for you, so if you just write in through the chat box your information, just so we have it for our records. We'll go to Yolanda next.
Oh. Hi, can you hear me?
Yep, go ahead.
I've never been on this side of the table. I'm Yolanda. I'm a registered dietitian and a certified diabetes educator who doesn't have the new title down that Stephen just gave. But lucky enough to work with the presenters today.
Thanks, Yolanda. Dr. Steve Shane. Dr. Shane, you should have gotten a notification saying we're asking to unmute you. So if you just accept that, we should be able to hear you. Yeah, Donna Crowley, school nurse in Fallon, Nevada. Thanks, Donna. Great to have you today. Dr. Shane, do you have a microphone there? Oh, we lost him. All right, we'll keep going then. Dr. David Bayen. Go ahead and unmute him.
Oh, hi. This is David Bayen. I'm in internal medicine.
Thanks, Dr. Bayen. Always good to have you. Somebody joined by iPhone. Go ahead, we can hear you.
This is Katie Damon, registered dietitian at Community Health Alliance.
Thanks, Katie. Good to have you. And there's another person joined by iPhone. We'll unmute you if you could introduce yourself, please. All right, maybe we don't have audio for you there. So if you could just write it through the chat box, letting us know who you are, where you work, that sort of thing, that'd be great. All right, so thanks everybody. Again, welcome to our Complex Pediatrics Echo Clinic for the day. So glad you could join us. So we'll start now and see if there's any cases that we can help you with, any patients that you've seen in the past week or two that you have some questions about. So anything that we can help you with today, feel free to unmute yourself, and we'd love to discuss that with you. So Yolanda, Dr. Bayen, Adana, Katie, any patients that you've seen that you might want to run by the team here? Okay. Dr. Bayen, we'll unmute you. Do you have anything?
I don't typically see kids, but just in case I get a surprise here and there.
Gotcha. Okay. All right. We've had a couple others join us. Dr. Dalton, are you there?
I am here. Yes,
Hi,
I'm a family med doc in Cali, Andy.
Thanks, Dr. Dalton. Any cases that you want to run by the team today?
Sure.
Okay. We'll take it.
Well, no, I just have a 19-year-old that's having some asthma issues forever and ever, but most of his issue is non-compliance. he's found that the Kenalog shot takes care of things, and now it's not effective for him. So I've sent him off to an asthma specialist, and they're doing their things
Okay.
there. But yeah, nothing too fancy yet.
Got it. No problem. Thanks, Dr. Dalton. All right, we're having quite a number of other folks joining us here. So Dr. Shane, do we have audio for you yet? Dr. Shane, go ahead. We can hear you. Oh, it sounded like we had something for you there for a second, and then we lost you. Is there another microphone unit you have? Okay, maybe not. Somebody else joined by iPhone. Sounds like you're unmuted. Could you introduce yourself, please?
Hi, my name is Jasmine Magana. I'm a school nurse.
Wonderful. Good to have you today. Which county are you in?
Washoe County School District.
Thanks, Jasmine. Good to have you today.
Thank you.
I think that's it. I think that's all the new folks who joined. So again, we're seeing if there's any cases you have that we can help you with today. Anything you'd like to run by the team? All right, we have a couple others join us, so I just want to make sure we do introductions for you. So A. Dahlstrom, we'll unmute you. Could you introduce yourself, please? Do we have a microphone for you? Okay, maybe not. And looks like the other one left. So we'll get going here with today's presentation. But throughout the presentation, if you think of any cases, think of any questions, feel free to interrupt, unmute yourself, or write in through the chat box, and we'd love to help you with those. Go ahead.
Oh, I'm going to start. Okay, Lori. Stephen and I are going to talk to you today about technology and diabetes. So, you know, I started with Dr. Eckert about 9 years ago. Before that, I was over in the pediatric ICU primarily, and there has really been, and I would say the last 5 years, a big explosion in terms of the technology that we're seeing to help manage diabetes. And yeah, it's been fun to try to keep abreast of it. So we're going to talk a little bit today about that technology.
Yeah, I like to tell my patients that there's no good time to have diabetes, but it's a good time to have diabetes with all of the new technology that's out.
Yeah. So, and you know, the reason there's been such a push with technology is it's hard for kids to achieve good blood sugar control. And if you talk to any kid, they all focus on their hemoglobin A1C. Well, what's your A1C? What's your A1C? And oftentimes they lie about their A1Cs just to look better to their friends. But it's one of the first questions Stephen and I get in diabetes clinic. What's my A1C? What's my A1C? It's the kid's question. It's the parents' question. And there's really a focus, you know, when we first started doing diabetes on A1C. Our goal with most of our kids is right around 7.5%, because we know that A1C is going to minimize long-term complications, but is also going to minimize the risk of a significant hypoglycemic event.
Yeah, it's the A1C, we're kind of moving more and more toward getting away from that.
Yes.
And looking more at time and range. So because the A1C, so this is what an A1C of 7% can look like with varying levels of control. So in that first example where 40% of the time they're high and 20% of the time they're low, and 40% of their time they're in range, which is defined by between 70 and 180, I wouldn't call that great control, even though their A1C is 7%. What we would want to see is over there on that right-hand side where 100% of the time they're in range and their A1C is 7%. So we're looking more at time and range now, and the new technologies are allowing us to see that.
And achieve it.
Yes, yes.
Easier. An interesting thing too is one of the newer closed loop insulin pumps on the market, even when looking at time and range, they have set goals for like how often you wear the sensor and how often you're in the automatic mode. But even with that technology, their goal for time and range, that time where you're between 70 and 180, is still only 75%. So, and this kind of comes in too, there's a lot of parents get super frustrated at their kid because they're 200, they're 300, they're 70, but even a computer program, a glucose monitor and a pump, they only want you or try to get you in that range 75% of the time. So expecting a 13-year-old, a 10-year-old to be in range is unreasonable. And then I just wanted to throw up some of the insulins out there, just because they're important when we start talking about this technology. So we have these rapid-acting, short-acting bolus insulins. These are kind of what we think of as our mealtime insulins. So we have Humalog, Admelog, and Novolog. All three of those, they have a slightly slower onset of action, about 15 minutes. So those three insulins are ideally dosed 15 minutes before a meal, which is difficult. I mean, it would be difficult for me as an adult to give my insulin 15 minutes before I ate. Some of the newer insulins we're seeing on market are Apidra, which is a 5-minute onset of action, and then Fiasp, which just got FDA approval for use in pediatrics. So between 1.5 and 2-minute onset. So that fits life better, just being able to give your insulin and then eat. We have some newer insulins too. Toujeo and Tresiba are two of the newer long-acting insulins. So these are your basal insulins, your background insulin. Your insulin is just kind of working in the background for 24 hours. Toujeo is 18 and over, so we don't use that a lot in pediatrics. We do use Tresiba a little bit more. We do start about 75 to 80% of a Lantus or Levemir or Basaglar dose. The interesting thing about Tresiba, though, just knowing it takes about 4 days to reach steady state, so you're going to be fighting highs for about 4 days. Likewise, if you lower the dose or raise the dose, you're not going to see the full effects right away. And then I put in other insulins because these MPHs and these regulars are what a lot of our type 1 diabetic community refers to as Walmart insulins. So if you do have a patient saying, well, why don't I just go get the Walmart insulin? They need to realize that they're not interchangeable with the insulin that they're currently on. But they have very similar sounding names. And there have been case reports of people dying from thinking these insulins were interchangeable. In my opinion, probably a higher risk of lows, wouldn't you agree? Yeah, because people that have used them, they're older insulins. But anyway, they're out there. They can be used somewhat safely, but people need education to use them safely. So if you have any patients out there wanting to use Walmart insulin, send them our way. Did you want anything to that, Stephen?
Tresiba gives a window, since it's a 42-hour insulin, where if someone forgets their dose, they can take it when they remember rather than having to wait until the next day. So it gives a little flexibility, especially in kids that might not be the most consistent with taking their long-acting at the same time.
Yeah, good point.
Is there a possibility for insulin stacking with Tresiba?
It's lower. We do, if they give their dose late, they do recommend not giving. So let's say a patient normally takes their Tresiba at night, and then the next morning they wake up and they say, oh darn, I forgot to take my insulin. You can go ahead and give it the next morning, but you can't give the next following dose unless it's been at least 8 hours. So if it's before 8 hours, there is some risk of stacking it, but there needs to be 8 hours between the dose, and the risk is lower. The risk of lows with Tresiba and Toujeo in general in studies are lower than the risk with Lantus, Basaglar, or Levemir.
Thanks for the question, Dr. Bayan. Any other questions about insulins?
All right, we're going to move on to insulin delivery. So those of you that have been in healthcare long enough remember pre-pen days when patients would use vials and syringes, and people would even reuse glass syringes and boil them. We've moved beyond that, thankfully. I would say most of our pediatric patients, we don't use vial and syringe for. We use insulin pens. So when I first started this about 10 years ago, there were only full unit pens, meaning each click of the pen was 1 unit. We now are down to half unit pens, initially via refillable cartridge, and now we have a disposable half unit pen with the Humalog insulin. And then, you know, of course, we'll talk a little bit more in depth about pens and insulin pumps, but we now have insulin pumps on the market. The 3 manufacturers that make them for patients with type 1 diabetes are the Medtronic insulin pump, the Omnipod insulin pump, and the Tandem or T-Slim insulin pump. Do you want to talk a little bit about how insulin pumps differ from pens and shots with basal bolus?
Yeah, I think it might be the next slide.
Oh, we
Is
might.
it?
Oh,
Is it the next slide? No, CGMs. I think there's a slide coming up, but insulin pumps give a little bit more flexibility to the patient as far as we can give fractions of units rather than just a half unit. So if somebody needs 2.43 units, they can do that with an insulin pump. Also, with their algorithms, it's taking into account insulin that's on board. And, you know, if somebody ate, 2 hours ago and dosed for insulin, it's going to help them dose their insulin for that next meal or whatever they're going to eat next, taking into account, hey, you still have some insulin that's working in your body. So it also helps protect those kiddos and anybody with diabetes that's on a pump from low blood sugar.
We also have continuous glucose monitors on the market, and I really think, for me, this has been a big game changer in terms of diabetes. Just in the way most continuous glucose monitors work is it's a little device that's inserted that can be in your subcutaneous area anywhere from 7 days to 14 days. They read blood sugars between every minute to every 5 minutes, and you can either passively get that information by it being sent to a device, or you can actively get the information, the blood sugar readings, by scanning the device. And they're all a little bit different in how they work. The nice thing about glucose monitors is not only do you get a reading, but you get a trend. So you can see on this iPhone over here, this patient is 110 and their blood sugars are holding steady. So it just allows patients to make more informed decisions. So let's say you've got a kid, going into football practice, which would generally lower blood sugar, and their blood sugar is 150. So that patient could be 150 going straight up, in which case he might not need a snack to prevent a low blood sugar during practice. He could be 150 holding steady, so he might need a 15-gram snack before he goes in. Or he could be 150 on a free fall down on his blood sugars, so he might need a really big snack to keep his blood sugars in target range during exercise. So it gives really good information. And I've put some kids on this and young adults on glucose monitoring technology and have not changed their insulin doses at all. Now, again, this is just anecdotally, but they've lowered their A1Cs just by knowing where they're trending with their blood sugars.
We just had a question about which one was recalled, the Medtronic. Do you want to speak to that, or are you going
The
to address it?
So the Medtronic, I can speak to that. It wasn't the Medtronic CGM that was recalled. It was the Medtronic 630G and 670G. The way the pump works is there's a little ring at the top where the insulin actually goes in, and that ring is made of plastic and it's breaking off. So, inspect the ring. It's at the top of where they insert the insulin. And if it's damaged or missing, because it can be totally missing as well, they need to stop using it right away because it can underdose and overdose insulin.
I think we're getting to a point with continuous glucose monitors, and I know DEXCOM is fighting for it, where these are going to become the standard for diabetes care rather than an exception. And so hopefully we'll move to a place where insurance companies will have to cover these more often. But yeah, DEXCOM's fighting to get these as the standard for type 2. So I think we'll be seeing that in the next few years.
And we'll talk a little bit more in depth about each one, because like anything, they have their pros and they have their cons. Right.
Yeah, go ahead.
So then there's the tried and true, just glucometer, right? But now we have a lot of glucometers out there that will actually upload data to an app on the phone. So they're trying to include a little bit more technology with the meter rather than just seeing the numbers on the meter itself. It'll actually send it to an app. Of course, the insurance companies kind of tell you which meter you can use. And then, of course, there's personal preference, right? So when I was in the adult world, there were some people that wanted a larger meter so they could see it and hold it versus some of these smaller guys that are out there. But that might speak to a level of techy person that may have diabetes. So this is actually an exciting, to me, an exciting technology that's out there. It's called Inpen. And so this is an insulin pen that actually uses an app to help tell you how much you need to dose. So this is number one for patients 12 years and older, and it gives you the ability to get half unit increments even with Novolog. So this is a Novolog pen or a Humalog pen. They're actually two different pens with two different cartridges. This app has a calculator, and I think it might be the next slide. Oh yeah, so calculators after this. But so this screen is the home screen, and it shows, hey, this is what your blood sugar was, this is how much insulin you took, and this is what time is there. Right there, middle of the screen, you see how much active insulin is there. And so this app is actually helping the person with diabetes know how much insulin is on board still. And the bolus calculator that they have takes that into account. So it's very much like a pump, but it gives the freedom of a pen if somebody doesn't either want to be on a pump or, oh, their pump broke, they still want to have some of those features. The Inpen gives them that knowledge, and it just connects via Bluetooth to the phone. So I think it's pretty fun technology. We've started a couple patients on it.
Yeah.
So we're eager to hear back how it's going.
Well, and it'll give, one of the nice things about pumps too, for those of you unfamiliar with diabetes, is it gives some flexibility of when you can eat, how you can treat a high blood sugar, because the algorithm in the pump takes into account that active insulin or that insulin on board. So you don't overdose yourself on insulin, you don't stack up your insulin doses and create a hypoglycemic event. There's never been any technology out there to do that with pens and injections before. So this is really the first time we've seen this technology. So kids that are, starving after diagnosis that want to eat every hour, it's kind of hard to do that because you can stack your insulin and go low. But using this pen and the calculator, it's going to take into account that active insulin and minimize that risk for these patients.
Is there any discussion about doing this with any of the long-acting insulins, just for tracking purposes? Not that you're going to keep.
You can actually track it through.
You can.
Yeah.
And set a reminder through the Inpen app. Yeah. It doesn't. I shouldn't say it doesn't track it.
Like automatic.
It's a reminder.
This one will show you if the dose was given, because the pen sends it to the app. So I like it for compliance. I'll know if the kid's actually giving insulin versus them just telling me that they're giving insulin. But it won't do that with the long acting. It's just, you're right, it's just a reminder.
So that's a picture of the dose calculator there. So they still have to carb count accurately and put in their blood sugar. There's a couple meters that will automatically upload to the Inpen. I think it's like 5 or 6 of them. So if they check their blood sugar, they wouldn't actually have to enter it in. And then it gives a recommendation. So it's not automatically dialing the pin and then they take it. The person with diabetes still has to take, in this example, the 3.5 units. But we get reports and it'll tell us if they did that recommended dose or how many times they overrode it. So we do get these giant reports that are pretty nice and pretty detailed. So,
thanks.
Oh, go ahead.
Was there a question? I'm sorry.
Comment from Dr. Mayan. I think that if the app includes winning gold coins and other sorts, kids will be much more compliant.
I like it.
You know what? That's actually really good feedback.
Yeah.
This is a new company, so this came out of somebody that wore a pump, right?
Yeah. So the CEO worked for Tandem, and then he got diagnosed with type 1 diabetes when he worked with Tandem. and went on a pump and didn't like it, so he created this technology. Yeah.
Yeah, but you are right. With kids, that would be a
Yep.
Some kind of reward is necessary.
I'll let them know to give you a royalty.
Thanks, Dr. Maya.
All right.
So here's a picture of some of the reminders. So you can see it. You have a long-acting reminder, and then you can set reminders for breakfast is usually between this time, lunch between this time. And so when we get those reports, we can see if they missed a dose. And so you can also get DEXCOM technology with this. It doesn't automatically populate their blood sugar because it runs, what, like 4 or 6 hours behind. I can't remember what Holly told us, but we can see just the overall trend with the DEXCOM when we print out the reports. So we can get those reminders about different guys. So
yeah. And then it reminds the patients who don't go through a whole cartridge of insulin just to replace it every 28 days. So that's some good, they've well thought out, I think.
Yeah, yeah. And that's a picture of the report that it can send. So what the patient does is they download the report on their phone, and then they can just send it to an office through the app. So
yeah, so they can fax it, email it,
yeah.
send it to a printer.
Mm-hmm.
So it takes the burden of downloading the data off of us and kind of puts it back on the patient as well. Oh, and then it'll tell you if the temperature of your insulin's gotten too warm too, which this actually happens quite often in summer. We get a lot of calls in the summer for kids that get ketones, and it's because their insulin went bad. They left it in the car, they left it in their bag in the sun, various things. This kind of nice too.
And the Inpen has a 12-month battery life. You don't change the battery after that 12 months. You just toss it and get a new one.
So we're going to go into a little bit more detail about the differences between the continuous glucose monitors that are out there. So DEXCOM, Medtronic, the Freestyle Libre, and the Eversense. The latter two are only FDA approved for use in 18 and over. You want to do DEXCOM?
Sure. So the DEXCOM G6, we like it is the only CGM out there where you don't have to calibrate with a finger stick. So it's only FDA approved CGM that you can make dosing decisions upon. So we like the DEXCOM. It has a 10-day wear time, depending on how sticky someone's skin is, or if they're really, really active. The adhesive may not last that long, so it's kind of up to the patient. So no calibrations are required, but you still can calibrate if you feel like things are off. We always tell patients that you need to check your blood sugar if your symptoms don't match what the DEXCOM says. It's a pretty good idea, and then they could calibrate if it was pretty far off. It has a 2-hour warm-up when you put a sensor on, so that's also another time when they would need to check their blood sugar with a meter. And then if the DEXCOM is ever reading over 300 or under 80, we ask them to confirm with a finger poke. The cool thing about this is the patient with diabetes can use their phones, as long as it's compatible with the DEXCOM G6 app, but can use their phones as their receiver. And so if they're doing this, up to 10 people can follow along with their blood sugars and get the same alerts that they're getting. So it really helps parents kind of put them at ease if their child's going to be at a slumber party or at the lake or 15 states away, because they can see their blood sugars just like the kid could on their phone. You'll see a picture of the Apple Watch there. The Apple Watch is not a receiver yet, but it will bring up blood sugars because they would have the DEXCOM G6 app on there.
But they're working on making it a receiver, hopefully soon. Which would be nice for, because this uses Bluetooth technology too. So if you get out of range, you get data loss, or you won't see it in real time. So, you've got a 2-year-old walking around with a DEXCOM, 3-year-old walking around with a DEXCOM on. They got to have the phone by them. So our teenagers, it's not a problem, right? They always have their phones on them. But, using that Apple Watch, a smaller device as the receiver would be hopefully in the near future, they're predicting.
If they're using the DEXCOM receiver, the receiver that comes with their DEXCOM as the receiver, there's no following by anyone can do that.
Yeah.
So, side note.
And the thing I think I like most about DEXCOM technology is it is actively sending that data to the receiver. And so within the receiver, either the app on the phone or the DEXCOM receiver, you set alerts and you get to choose the alerts. Like I want to know when the blood sugar is 80, 90, 70, whatever you choose your setting to be, as opposed to some of them where you have to scan it to get the reading. And just for nighttime lows, a parent being alerted that their kid is low in the middle of the night so that they can get up and treat them, I mean, can be life-saving. So another CGM on the market is Medtronic. Their most recent sensors, their Guardian 3 sensor. This one is difficult to use as a standalone sensor, but can be used as a standalone sensor. All of my patients, though, use it integrated with an insulin pump, either the 630 or 670G. And we'll talk a little bit about the integrated systems in a minute, which is what we call our closed loop pumps or artificial pancreas technology. It has a 7-day wear. It requires calibrations. Usually, on average, I would say 3 to 4. I've had some patients have to calibrate at 10 to 12, but the average is about 3 to 4 calibrations a day. But again, it's difficult to follow along with this app or with this CGM.
There was a question about the acetaminophen.
Yeah.
Oh, yeah.
With
Yeah.
DEXCOM.
Yeah. So the older versions of DEXCOM, Tylenol would interfere with the readings. So we recommended not giving Tylenol, or if you gave Tylenol, checking blood sugar readings. So that was up until the G5 version. With the G6 version, we no longer have any Tylenol interference with blood sugar readings, which kids, you know, with fevers and febrile illnesses get quite a bit of Tylenol.
Donna, does that help? Okay, thank you.
Okay, then there's the FreeCell Libre. So Libre comes with its own receiver, I guess you could say, but you're not going to get readings on it unless you scan the actual Libre device. It does have a longer wear time, 14-day. So it's helpful. But again, you're not getting active readings, so you actually have to say, okay, what the heck's going on here? Let me see. There is an app that would allow friends and family to follow it, but again, you're not getting real-time data at that time, so it would require the 18-year-old or 19-year-old or however old they are to be compliant and scan it to be seeing those things. So it's another option out there. It's not integrated with any pumps yet. I'm sure at some point they will. But.
In the work, I think Bigfoot signed with one of the artificial pancreas technologies that's coming to market, signed with Libre. The one thing that is nice about Libre is it's a lot more affordable than a DEXCOM or a Medtronic CGM. Sensors without insurance, a month worth of sensors is about $60 as opposed to thousands of dollars with some of the other DEXCOM Medtronic systems. So I have occasionally some of my patients like this, just they don't have to check their blood sugars, they just scan, so it's more affordable than other stuff out there. So now we're going to move into insulin pumps. There are a lot of advantages of insulin pumps, like we talked about a little bit earlier. Less risk of low blood sugars from stacking insulin. You can give fractions of units. You know, you don't have to inject in public. Believe it or not, there are a lot of people that inject their insulin in public and get yelled at. So, you know, you can eat more frequently. You don't have to wait the recommended 2 hours between eating and 4 hours between correction doses. I think one of the biggest disadvantages is there's no long-acting insulin. So insulin pumps work by infusing a basal rate, so a slow background insulin. But this is your short-acting insulin, your Novolog, your Admelog, your Apidra. And then whenever you eat, you tell the pump how many carbs you're eating, what your blood sugar is, and it calculates a recommended dose. But if you ever have dislodgement, kink, malfunction of that pump, there's no insulin in your system keeping you safe. There's no Lantus there, there's no Levemir there, there's no long-acting insulin. So your risk of diabetic ketoacidosis is greater. So in our office, we tend to only put patients on it that are somewhat compliant. They check their blood sugar so they know if they go high, so they know to check for ketones, and they know they're having a pump malfunction. So that's kind of, and really when you also order a pump, you have to submit 3 months worth of blood sugar log showing that someone is checking their blood sugars 4 or more times per day, because the pump manufacturers know too that in the wrong hands it can be dangerous. The other limiting factor is the cost, especially with families with high deductible insurance. So there are 3 pumps, like I said, out there. The Medtronic and Tandem are tube pumps. The Omnipod is a tubeless pump. And they all have their various advantages, disadvantages. Medtronic and Omnipod are waterproof. Tandem is not. Medtronic uses, and Omnipod uses batteries. The Tandem is rechargeable via USB. So, you know, some have remote ways to bolus patients where you can run around and chase your toddler and just bolus through a handheld device. It's trying to like have them hold still for 5 minutes to plug in some stuff. So they all, you know, some have linking meters, some don't. They just all, and I guess my point is everybody has different needs and what they want in their insulin pump, and they really should have a choice in what best fits their lifestyle. So we're hoping that insurances won't limit that choice, but we're starting to see that. And then in terms of insulin pumps and DEXCOMs, once we integrate those two, that's what we call a closed loop system or artificial pancreas technology. So the patient must be wearing a continuous glucose monitor. They must be wearing an insulin pump. Currently, these are 2 separate devices, so the kid has to wear 2 things. Pumps are changed every 3 days, glucose monitors every 10 to 14 days. What happens though with this artificial pancreas technology is there's predictive algorithms built in. So if the glucose monitor is predicting a low blood sugar within a set amount of time, it sends that data to the insulin pump. The insulin pump automatically adjusts insulin upwards or downwards based on predicted blood sugars. So it takes some of the burden off the patient. But it's not, I think Stephen and I can both attest to the fact that it's still work. It's not, oh, I just put these things on and I go about my daily life. There's still a lot of work that goes into this technology. I'll let you.
So the Medtronic 670G, so this is one of the pumps that was recalled. They have something called auto mode, and auto mode adjusts the basal insulin every 5 minutes based on those CGM readings, so up or down. It also has a suspend before low feature, so if it predicts that blood sugar is going to be low in the next 30 minutes, it's actually going to suspend the basal rate, so no more insulin will go in until that blood sugar starts coming up, and then that basal rate will restart. One con of this is it does require a finger stick calibration to stay in auto mode. So someone has to be compliant with their finger sticks, and if the pump says you need to calibrate, you have to calibrate or it's going to kick you out of auto mode and you don't get those automatic adjustments. It will still protect for lows though, but not the auto mode for the...
You have to go in and... So in auto mode, you can, with the Medtronic closed loop, you can frequently be kicked out of auto mode if you don't do certain steps. If your blood sugars are high for too long, if it's given your maximum amount of correction dose or basal rate to bring you down in, if you don't calibrate in a timely manner. So a lot of my patients get kicked out of auto mode because a lot of my patients are teenagers wearing this, and teenagers just don't do what they're supposed to do, right? So this requires, I think, to stay in auto mode in this pump does require a lot of work. And in fact, studies have shown that 1 in 4 adults don't even stay in the closed loop system because it is so labor intensive. So I'm sure the numbers, I haven't seen any teenage data, but I'm sure the numbers for teenagers are even higher. If you get flipped out of auto mode, this is the other thing with teenagers, it won't suspend before low unless you go in and turn that feature on when you're in manual mode. So I think it's a good pump. I think it's a safe pump. Medtronic has a great history. I just don't know that it's the best pump for teenagers. You know, I have younger kids on this where the parents do everything. It's a great pump. It's a really good pump. It does what it needs to do. One of the newer pumps that just came to market with their fully closed loop, though, is Tandem or T-Slim, and their technology is called Control IQ. We're just starting to see patients back with this technology, so we don't know all the bugs or the way that children will exploit it. But so far, it seems like it might be a good system. It is not going to kick kids out of the auto mode. It will always stay in the auto mode, which is kind of nice. It is integrated with the DEXCOM G6, which is a great feature because, as you know, there are no calibrations required with this CGM. So I think for teenagers and even younger kids, just kind of taking some of that burden of the disease off of them is important. You can also set sleep modes with this. And do we have more slides? I don't remember on the sleep mode.
I don't think so.
So the sleep mode is kind of nice because it sets your target blood sugar a little bit higher. So in auto mode of this pump, the range that it's trying to keep you in is 70 to 160. And it does that by increasing and decreasing basal rates based on predicted blood sugars within 30 minutes. When you go to sleep, however, people don't eat, right? So you can actually get a little bit more aggressive with insulin during sleep because you're not eating. But the way to offset the risk of low is Tandem raises that target blood sugar from 70 to 112. But then it tries to keep it between 112 and 120. So you're going to get a lot more aggressive increases in basal rates at night to keep you there. The only problem is I had a kid the other day, just finding the little subtle nuances, who butt dialed sleep mode. So he put his pump in his pocket still on and put himself into sleep mode. And then all of a sudden he's eating and he's going low all the time. And he realized he was in sleep mode. So if you have a kid with a lot of lows, just might want to think about that. And then it also has a nice exercise mode. And what exercise mode does is it raises your target blood sugar even higher, up to 140 to 160. So a lot of kids with exercise, not every kid, a lot of kids with exercise will go low during exercise. So this is a nice feature that you can activate. Unlike sleep mode, where you can set two different set times where you go into sleep mode. So you can set like a weekday sleep mode. So if your kid goes to bed at 9 o'clock every night, you can start sleep mode Monday through Friday at 9 o'clock. And then if they stay up till 11 o'clock on the weekends, it can start later on the weekends. So you can set that sleep mode, or you can just activate it nightly, either way. With the exercise mode, you can't set it. You need to actually activate it. So.
Well, it sounds like the next step for all the pumps is to hopefully include glucagon as a counter-regulatory hormone, which may mitigate some of these things. I mean, we're still going to have to be really careful, but adding glucagon in is going to be, I think, a huge step in really, getting a tighter control level. So and minimizing
getting the shelf-stable version.
They have it.
They have it.
Yeah.
Okay.
Yeah. By stock now.
Through FDA.
It's down to $4.
I know.
Sure.
We'll talk later.
And you may have families coming to you too with some of these non-FDA approved technologies there, and this is not. I mean, we put 2 up there. There's so much more out there that families are using. I do have one patient using RileyLink, which turns the Omnipod, or that tubeless insulin pump, into a closed loop system using a DEXCOM. And it's such a difficult water to navigate. I've actually talked to the legal department at the hospital where I'm employed, because can I give recommendations on what I see based on trends on a non-FDA approved technology that I don't really maybe fully understand? So I've really kind of put the onus back on the parent. I can tell them what I see, but I can't really make recommendations. But fortunately, I think most of the people using these technologies are also families that are really well informed and have a good understanding, because it's not easy to do by any means. I just learned the other day about Night Rider Glucon.
Monday, I think.
Yeah.
Yeah, and so Night Rider turns the Freestyle Libre into a DEXCOM, essentially. So you're getting real-time data from it. So I don't think you can integrate with that, but at least turns the
But at least you're actively
Libre
getting
into the
your
DEXCOM.
Libre readings
Yeah.
and can be alerted in case of low. And then speaking of glucagon, Dr. Eckert, there's so many new devices out there just to administer glucagon. So glucagon is an emergency medicine. It's an injectable medicine. It's used in the event a patient becomes unconscious or starts having a seizure from a low blood sugar. But the old glucagon requires the family to take the powder, which is the medicine, and it comes with a syringe of sterile water, and mix the two together, draw it up, get rid of the air bubbles and all the air. Meanwhile, their kid's having a seizure on the floor.
Right.
And then inject a large intramuscular injection, which they never do, right? Subcutaneous, yes, but not intramuscular, a big intramuscular injection. So as a nurse, I would, and not my child, I would be shaking having to administer glucagon and trying to draw it up. So recently they come out with the nasal glucagon, which is this. It comes in a little gray case. You take it out. There's a little gray case. You take the medicine out. You put it in the child's nose, and you just compress until the green line at the bottom goes away. It disperses the glucagon powder into the nose, and families are always like, well, do they have to sniff it in like Flonase? I'm like, no, they're unconscious, they're having a seizure. So they don't have to sniff it in, it just gets dispersed and will raise blood sugars. And then the other.
Then there's another one called Gvoke, and they have a pre-filled syringe where the glucagon's already mixed. That's the one that's out on the market right now. But they also have an auto-injector, much like an EpiPen that they'll be releasing later this year. So again, pre-mixed glucagon, shelf-stable, that can be given. So I think that, gosh, those have been 6 months or so on the market.
Yeah.
So, you know, the trend in diabetes technology is definitely heading in the right direction.
For sure.
I think that's all we got. Yeah.
Yeah.
So you probably don't have official information, but even anecdotally, help them understand, like in a fairly well-controlled patient, if we switch them from multiple daily injections to a pump, how much of a change would you see in A1C? Not that that's the end-all be-all, but more importantly, perhaps, what are the lifestyle changes that you might see in those patients, especially that the parents report?
Typically, I see A1Cs go down just because the kid can eat when they want to eat. They're not hopefully sneaking food like maybe they were before. So you've got a kid who wants to eat, they're hungry, they want an apple. The mom says, no, you just ate an hour ago, wait another hour. So the kid takes the apple and eats it in the room. You get rid of that with a pump. They're allowed to just eat more often. I think they also give insulin more often typically on pumps, just because you don't have to go, you don't have to get a pen, you don't have to put the needle on the pen, you don't have to prime the needle, you don't have to then give your injection, you don't have to take the needle off, dispose of the needle. I mean, giving a shot of insulin is a multi-step process. On a pump, you just, reach down, plug in your blood sugar if you want, and your carbs, and hit go. So it is a lot easier to do on pump technology. And then you get fractions of units. So you can fine tune that diabetes management. I think it increases compliance, and then you also get the advantage of more fine tuning of the dose that you get.
Maybe more reassurance when kids are doing sports or spending the night, those kinds of things. I mean, the flip side, of course, is what you talked about. If the pump does malfunction, you got to do something right now.
Quickly.
Yeah. But in general, I mean, do you think there's more freedom that the kids are given because of the pumps?
Yeah.
Or can you tell?
I think so.
Freedom by the parents.
I think CGM allows more freedom by the parent.
Yeah.
Pumps too, but I definitely think parents knowing what their kid's blood sugar is. Especially, you know, and with diabetes, it's always so hard because kids' job as they grow up and become teenagers pull away from their parents and create their own identity. But with diabetes, they're always pulling that child back in. And this is, CGM is hopefully one way parents can let go a little bit and let their kid be a kid. I've also had parents constantly yelling at their kid about high and low blood sugars. So that's part of our spiel when we talk to these families and we're putting kids on glucose monitors is you can't freak out and you can't text them all the time. And you just like, they're okay. If it's a low, we always say intervene. You need to know that they're treating it. But for a high, give them some time to figure it out.
A question here from Adana. Which of the options for glucagon do you think are best for use at school by a school nurse, nasal or injection?
So I'm a bigger fan of the nasal because it removes any human error that could come from injecting or mixing or whatever it happened to be. And in controlled studies, which got the FDA approval, the nasal glucagon called Baqsimi was just as effective as a glucagon shot. And so in an emergency situation, likely going to be more effective because again, there's shouldn't be any human error with just put it in your nose and not in your nose, their nose, and make the green line disappear. So,
and then if you have clinical aides or people that are not medically trained administering it, I think, yeah. Even nurses, if you don't, school nurses, if you don't give a lot of glucagon, it's hard to do. It's hard to mix. It's hard to administer. I agree.
Thanks for the question. Any other questions before we wrap up for today? Feel free to write those in through the chat box or unmute yourselves, please.
And while we're waiting for any questions, next month, Amy Hughes-Lansing is going to be talking to us about adherence issues and other behavioral issues associated with children with type 1 diabetes as well. So I hope you'll join us. That is Friday, March 13th. Right.
Correct, yeah, I'm pulling that up right now. What is happening? Yeah, sorry everybody. Yeah, so Friday, March 13th, 12 to 1, mental health screening and brief behavioral intervention for pediatric diabetes. So I hope you'll join us then. Thanks everybody. I sent the link out through the chat for you to do the evaluation to claim your CME or CEU credit. And in the meantime, if you have cases that come up that you'd like some help with, please reach out, send those to us, and we can talk about those during the next session. Thank you everyone. Have a great rest of your day.
Thank you.
Thank you.